So,
Yes.
can you explain with regard to the resistant refractory rickets? Is it important or is it a seizure? What is that? You told it, according to your description, it is a seizure disorder. And child was treated with seizure anti-epileptics and discontinued. Later on, there is nothing like that.
Yes,
No
sir.
seizure further.
Yes, sir. So,
So, so what you any other possibility? Child have a seizure and later having rickets, especially
could be
refractory rickets.
due to hypocalcemia is a
Yes,
possibility.
hypocalcemic seizure. So it could be a hypocalcemic seizure. What type of rickets it can cause? What type of refractory? Where will you? What type of refractory rickets you can get early hypocalcemic seizures, early ages? That's early infancy, probably.
Vitamin D dependent rickets.
Okay, so vitamin D dependent. Among vitamin dependent, which one? Type 1 or type 2? You know that
Type
there are two types of vitamin D dependent rickets. Type 1, where you get 125 dihydroxy vitamin on alpha hydroxylase is absent almost, or type 2 you may get a 25 hydroxylase is absent, not functioning properly. So is it a type 1 or type 2 means there's end organ
yes,
the receptor resistance. So is
yes.
it type 1 or type 2 you get a seizure,
Com-
or both you will get?
Commonly seen in type 1, sir. Type 1.
Commonly seen in type 1, but the seizure very early age is usually seen in type 2. That is a that is a receptor resistance, type 2. Type 1 you can get the seizure, but usually a bit delayed. Usually around 3 months to 6 months age is the usual onset. Whereas in type 2, where the resistance of the receptors you get very early, it may be early weeks. Within 2 weeks they may get the seizure. So in this case, according to history, it is not a hypocalcemic seizure. Okay, is it like that? Okay. So we have discussed what you think it's a refractory rickets because child received optimum treatment or treated for with the vitamin D sachet for almost 1 year. So still having not treated. So could you just describe what is how will you treat a nutritional rickets?
Nutritional rickets. For that, we have to firstly evaluate for the and identify the
Okay,
nutrition.
treatment. Okay, so mainly the
Mainly the
treatment.
supplementation of vitamin D and calcium. Mainly we supplement vitamin D according to Stowe's therapy. We can give either as
It's not a
800.
supplementation. Now it's not a supplement. It's a therapeutic treatment. Therapeutic dose. Okay. Stose therapy.
We
So what is stose therapy?
give
Stose
800
therapy.
international.
STO double S therapy. Okay. What is that?
So we are giving megadose of vitamin D in that Stowe's therapy. We can give either as 800 international units
Okay.
per day for 3 to 4 months, or we can give it as 1 lakh to 6 lakh international units per day for 1 to 5 days, or it can be given as
Is
60,000
it
international
one
units,
lakh or is it 1 lakh or 3 lakhs?
3 to 6 lakhs.
I think 3 to 6 lakhs given uh, uh, as a stose therapy. That means it should be given as a supervised.
Yes,
That's
sir.
the importance of stose therapy. So that is the best treatment modality can give. You are giving at your presence. So on the
Yes.
same on day one, you give all the dose together. Okay. Okay. So was this child having any risk factors or vitamin D deficient rickets? What are the risk factors of a nutritional rickets? You will be asking in the history. Suppose
We
you
can
have a child with rickets.
yes.
Usual risk factors.
Usually
So having
diet.
said that, we have some 25 questions in the question answer box. The first question is asked by Dr. G.
Sir, the risk factors include we
Okay.
can ask for dietary factors according to the intake of the dietary intake of the mother. If the child is exclusively breastfed and if the child is not receiving adequate diet containing vitamin D like fish and egg yolk, etc., or we can ask for the exposure to sun exposure is another risk factor. Decreased exposure can lead to decreased vitamin D synthesis, and then infancy is another risk factor. And then according to seasonal variation, in winter season we'll have less sun exposure, and there will be decreased vitamin D
Okay.
synthesis.
Very good, very good. So these are the main risk factors. One is baby not exposed to sun at all due to the customarily, the social custom. The child is being kept in the, not going outside, taking outside, or baby not given an exclusively breastfed baby not given vitamin D supplementation.
Yes, sir.
That's also another risk factor. Routinely, they should be given up to 1 year. If the baby was not given due to any reason, that is another risk factor. And the mother having vitamin deficiencies also, vitamin D resistance deficiency, especially mother due to the social customs, or mother due to unusual social circumstances not going outside. That's another important risk factor. And mother or baby receiving anti-convulsants like phenytoin and phenobarbital. These are also risk factors. Oh, this baby didn't have any. Okay.
No, sir.
So you know that this child is having a refractory rickets. Okay. Any other? What is the? What are the important points in the history to get a etiological diagnosis? You have chosen.
Sir,
What are the usual causes? Can you name few important causes you consider?
mainly
Refractory rickets, common.
Can be due to vitamin D dependent rickets, or it can be due to hypophosphatemic rickets, or it can be due to renal
Yes.
tubular acidosis.
So these are the three important causes which should be coming to your mind. So in this case, can it be a vitamin D dependent rickets from the history and all? So do you consider from the history
Yes, sir,
vitamin D dependent?
it is possible with the history of seizures at the neonatal period.
But
And then
but that point you cleared. It's only a seizure of not a hypocalcemic, was not treated accordingly.
yes, sir. And there can be
That
dental enamel erosions can be seen, which is also common in vitamin D dependent rickets. There is the history of dental caries in this child.
but
And,
that can be occur in hypophosphatemic rickets also.
sir.
Okay, so I think in this case, vitamin D dependent rickets, whether type 1 and type 2, very unlikely, because usually the most of the majority will be presenting at the age of early infancy, between 3 to 6 months, with hypocalcemic seizures. They'll be having irritability due to hypocalcemia, failure to thrive. There will be a motor delay. There will be having hypotonia. And so these are the important, and even they can have tachypnea due to the very soft rib cages, recurrent pneumonias. During the early infancy, they will be having a very difficult early infancy. This child is not having according to history.
Yes,
So that's the most important point to consider. The point suggesting that this child is very unlikely to have a vitamin D dependent type of rickets. Okay. So these are the important history you are supposed to include in the history. When you describe the history, you could have added that. Okay. So during the early infancy, was there any symptoms suggesting vitamin D dependent? Of course, rarely some lesser severe type of vitamin D rickets can present as a later childhood also, but very, very rare. Okay. So when you discuss the case, very rare condition will not be considering early. Okay. So is there a symptom of, can it be a hypophosphatemia rickets still?
yes, sir. It is possible because there is more lower limb involvement as in the history as compared to the upper limb involvement. And again,
Okay, that's a very important point. So you are considering that is an important point. That is having lower limb. Why not upper limb from the history?
because the chief complaint of the mother was the bowing of the legs as with which
Okay, so presented with bowing of the leg, presented with.
yes, sir.
Okay, so that is that's the one important feature of the classical teaching is that when a child presents with predominantly lower limb rickets, the most likely you have to consider is a hypophosphatemia rickets. Okay, then any other point to suggest hypophosphatemia rickets?
Then the fracture history of fractures, early fractures is present, and then
that can be common for all. That you
yes,
can not very specific. Okay.
yes. Then
Any other point?
age of onset is
Initially you
around
told.
1.5 years.
Okay, age of onset is slightly supporting hypophosphatemia rickets. When the child start walking, leads to deformities of the lower limbs. That's why they are presenting around. So even early, there may be some feature, but they are manifesting only once the child started walking. Okay. And what about any other one more point you mentioned previously? One more
seizures.
point in the history, you can take it in favor. Not seizure is seizure you cannot consider. Any dental?
Dental caries were present, and then no secondary dentition is delayed as per the mother.
Okay, so there is a subtle dental. You can add. You can take. You can argue that this could be a favor point in favor of hypophosphatemia rickets. Okay, so you got the 2 points. Okay, so did you ask about any features of a? You told it could be a resistant rickets, refractory rickets due to tubular disorders, also renal.
Yes.
So, what are the points you asked, or what are the points you are supposed to? History will be eliciting, suggesting a renal rickets.
And there was no history of any polyuria, increased urine output,
Polyuria, very good. Then,
and there was no history of any recurrent infections, urinary infections. Then,
oh,
failure to
you
plasma.
recurrent UTI. For what? Renal rickets, CKD. Are you considering CKD? Okay, CKD. Recurrent UTI. There was no. Okay. CKD can also cause refractory rickets. Okay.
Then, as per the mother, there is no history of any decreased weight gain or weight abnormalities are not complained by the mother.
Okay. So the FTT is one of the major. Usually, most of the time, those children with tubular disorders will be having significant failure to thrive. So that was not present. They are usually present with the failure to thrive rather than deformities. That's also one point you are considering. Okay. Okay. So a few more points you can consider. You can ask that. One is usually they will be having polyuria. You told salt craving. Usually savory food. Craving for salt and savory food are one important feature. You may get renal tubular disorders and specific. Which are the what is the commonest cause of proximal renal tubular acidosis?
It could be due to autosomal dominant or recessive conditions, and can be also associated with any other conditions like galactosemia,
Okay,
tyrosine.
so there are no so many causes. The commonest cause of mentioned as a cause of proximal renal tubular proximal renal tubular acidosis is a cystinosis. Cystinosis is one important. They are mentioned as. Usually they may present as what is the most specific symptom you can ask. It may be a very important clue for diagnosis cystinosis. You
Photophobia.
told it what is photophobia. So photophobia is a very specific symptom. You can usually appears around once the child starts walking, usually around 2 to 3 years only. Early infancy it may not develop. So child will be refusing to look into when the child awakes and goes outside the house. She may not straight away directly look at the sun. So the parents usually notice. So presence of photophobia in this case is very important. It could be a important clue for proximal renal tubular acidosis due to cystinosis. Okay, so by the way, is it a proximal or distal renal tubular disorder acidosis causing rickets, which is where we get rickets more commonly? Proximal or distal?
Proximal arteries.
Proximal artery is more
Significant, severe.
cancer. You get what is a what causes they may present with rickets proximal. What's the cause? What is the underlying cause
Due to the
in proximal artery?
bone resorption by the osteoclast activity, and due to the acidotic environment, there will be osteoclast
Okay.
activity leading to bone resorption.
Okay, so the bone generally act as a buffer for buffering the acidosis in renal tubular acidosis, but this is true for both proximal and distal.
Yes.
That is a bone resorption to buffer acidosis. This is one that can occur proximal and distal, but predominantly in proximal arterial rickets is predominantly due to phosphaturia. There will be a severe phosphaturia. So due to the phosphaturia, child develops rickets. Whereas in distal renal tubular acidosis, what is the cause? What is the reason for rickets?
Due to
Again,
bone.
one is for buffering the bone. That's one thing. Predominantly, it is hypocalcemia, secondary to buffering of the acidosis by the resolution of the hydroxyapatite and all. That mechanism you can just please refer. So this is a usually asked question: what is the why will you get rickets in proximal or distal, and what are the mechanism? Also, you should be well versed. So you can please refer further details. Okay, so these are the additional points for considering the refractory rickets. Specific history you can ask regarding to get to rule out or include renal tubular disorders. UT also you told renal rickets is possible. Of this, if it's a male, you can ask about the stream of the urine is very important, and any anomaly detected during the antenatal scan, recurrent UTI. Oh, these are the clues for the CKD, chronic kidney disease causing presenting as rickets. Okay. So now, from the till now, the history you consider hypophosphatemia rickets, isn't it?
Yes.
Okay. So you can you please discuss the family history? So what are the any clue for your diagnosis in the family history? Are you having, or did you? What are the clues you look for?
So as per the
In the
history,
family.
there is
That's another one important area, one important component, one important site. You may get a certain clue for a diagnosis in a refractory rickets family history. You have to analyze family tree in detail. Okay. So it's a non-consanguineous uterus. Please show the hello. Please show the family history. Okay. Yes. Yes. Okay. So you said you made a three-generation family very good. So that is needed because majority of the refractory rickets etiology is autosomal recessive or X-linked recessive, etc. You may get autosomal dominant also. So for identifying recessive disorders, you have included three generation. That is very good. Okay. So non-consanguineous parents. Okay. So what are the important points? You have mentioned a few points. Any history, any clue in the family history to get to support your diagnosis?
I know, sir. There is no history of any short stature or bowing of legs in the family, as per the mother, as per the history. And there is no mother and father are not affected as per the mother, and there is no history of any early sibling infantile deaths or early sibling loss in the family. So as per
Okay.
history,
So, very good. So infantile death, what did you ask specifically?
that
Early death?
can be seen in cystinosis, and also distal RTA can be associated with early sibling loss and infantile deaths.
Okay, so early sibling loss due to cystinosis is very important. Without treatment, if they are not able to give up to treatment, they can succumb. So why distal RTA? Why do you? Can they also be? Is there any mortality?
Yes, sir.
Distal
Can
RTA.
have,
What is what is usually distal RTA is a very disease which can be effectively treated. There can be very good prognosis you get in distal RTA. Whereas proximal RTA is there is a chance of going into CKD and early death is more common. Whereas distal RTA, if you are treating appropriately, child can have a near normal life with a lifelong alkali treatment and all. So, what is the reason? Distal RTA can have early deaths. Why? How?
can be due to severe acidosis or hypokalemia, leading to.
Yeah, okay, very good. So during the period of rapid growth, especially during the early infancy and early childhood, there is a very high increased need. There is a acidosis will be there, so the large requirement of alkali will be the to combat with the growth and all. So these children require large alkali early during to get a optimum growth, and during intercurrent illnesses, like suppose child develop any infection, significant infection, the requirement is very high. they may develop a severe hypokalemia, severe acidosis. They can, unless detected early and treated appropriately in an ICU setup, baby can succumb, especially distal artery. During infection, they can lead to severe acidosis and severe hypokalemia, and death is very common. So these points you have asked for, especially renal tubular acidosis, sibling death is very important. And there is no other clue because no family members affected. So you have asked for mother having short stature and a mother having or female maternal female siblings or maternal grandmother not having any short stature or any bony deformities like difficulty in walking, subtle changes. So you have included. So what is why what is the importance of these two history?
Because in
So this may
X-linked
be very important. Okay,
the
these 2 points may be very important clue for diagnosing what.
X-linked hypophosphatemic rickets can have carrier
Yes.
females will be slightly affected.
Okay, so X-linked hypophosphatemia rickets is the commonest cause of hypophosphatemia rickets. So you can get a very important clue if you are asking whether grandmother or the grandmother's sibling or mother sibling is having subtle difficulty in walking, or if the mother or grandmother or they are short. So that is a history that may be important because the manifestation may be subtle or minimal, may not be noticed. So that's the important history you have asked. That may be important clue for X-linked rickets, and no other family member affected. Siblings, father and grandfathers not affected means there is no autosomal recessive, autosomal dominant, or X-linked inherited disease is very unlikely in this. Mother is having short stature. Huh? Mother short?
Sir,
No.
according to examination, there is, but as per the history, she is not complaining of any short stature.
You have so you got a clue for short stature. Okay, so let it be that. Okay, so family history. Suppose the father is also having rickets. So what is your take on that? Father having, that means the abnormal gene has been transmitted from the father. So how will you analyze that point, that finding or that history?
It could be autosomal dominant type of hypophosphatemic rickets, which is
Okay, it could be autosomal dominant type of hypovascular rickets. Okay, what is not very unlike? What condition you can exclude? Suppose father is also affected. You can
X-linked.
exclude X-linked rickets, X-linked hypophosphatemia rickets. That is, which is the most common type of hypophosphatemia rickets. If the father is having any bony defect or any dental or any significant dental abnormalities, you can exclude X-linked hypophosphatemia. That's also important point in the family history you are supposed to, because there is no mainly it's not X-linked. The rickets is not X-linked. So X-linked rickets is very unlikely if the father is also having rickets. Is the father having any rickets or bony lesion? You have asked.
Yes, sir. No lesions.
You have specifically asked.
Yes, sir.
So you have to specifically ask, and even you can examine also. That's maybe an important clue for excluding. Okay. Okay, so few more minor points in the family history can give a clue. Is one is if the father, any family member having alopecia or any dental or deafness, all these may be a clue for certain inherited. Either hypophosphatemia rickets, alopecia can occur in alopecia,
Vitamin D dependent rickets.
vitamin D dependent rickets, especially type 1 or type 2.
Type 2.
Type 2. So type 2 vitamin D dependent rickets can be can be associated with alopecia, especially alopecia areata or totalis. Both are present. It may be a clue you can get in the family history also. You are supposed to ask deafness. What is the relevance of deafness in the past history of the child or the family history? Suppose there is a deafness, sensory neural hearing defect with the rickets, which are the usual association.
Can be seen in distal RTA. Can be associated with.
Distal RTA is a very commonly associated. So all distal RTA patients, you have to screen for sensory neural hearing defect. At the time of diagnosis, also they should be subjected for periodic yearly screening for deafness is indicator for dyslexia. Any other condition? You can also get in hypophosphatemia rickets also, especially X-linked hypophosphatemia rickets also deafness is common, and certain rare, extremely rare conditions of hypophosphatemia rickets like in vitamin D dependent type 2 rickets also you may get deafness. So it's one is dyslexia, then X-linked hypophosphatemia rickets, and type 2 vitamin D dependent rickets. So this deafness also an important point you are supposed to include in the history. So these are the specific points may help you to narrow down your diagnosis. Okay, so I think we have discussed family history. So any point in the development? Normally developed. No development delay. Okay. Dietary history you have included. Okay. So from the history, you consider it's a refractory rickets. Probably you are considering first possibility hypophosphatemia rickets. True, is it?
Yes, sir.
Okay. So the point in favor is age of onset. You told then lower limb predominantly affected, and one more point.
Dental issues, sir. Dental enamel.
Dental, and also you have mother having a short stature. Maybe that also helped you. Okay. Yes, coming to the so you can do a focused examination for your DD in the general examination.
Coming to the examination, general condition: child is alert and active, interacting actively, and vitals: pulse rate is 96 per minute, regular rhythm, normal volume and character. Peripheries are warm. BP is 94/56 in right upper limb in sitting position, which is normal for the age, and respiratory rate is 24 per minute with no accessory muscle use. There is no pallor, icterus, sign of clubbing or pedal edema, no lymphadenopathy, and head size appears normal. There is frontal bossing is present. Eyes are normal with no cataract, and there is a hard swelling of the clavicle, which is a heel fracture, and rachitic rosary is present. Wrist widening is noted bilaterally. Double malleolar sign is seen bilaterally, and there is coxa vara of the left hip. Genu vacuum of both knees, more on the left knee, with the intermalleolar distance of 12 centimeter. There is dental caries and no neurocutaneous markers. Nails and skin are normal. This is the findings of the child.
Okay, so general examination, the important finding you have identified. Why do you mention specifically about the head size?
There can be associated frontal bossing, and also features of hydrocephalus can be noted in some cases of rickets.
Hydrocephalus, which one? Which type? How is it a very specific point for rickets?
No.
Maybe may not be giving. Where will you get type hydrocephalus? Which type of rickets? What is the mechanism? Okay, so I am also not familiar with this hydrocephalus and rickets. You can get macrocephaly rickets, isn't it?
Yes, macrocephaly.
Rickets is a macrocephaly is one important. I thought you were considering macrocephaly. Macrocephaly can occur.
Yes.
Okay. Yes. Then you mentioned specifically no cataract. So what is suppose you get a cataract, how will you take?
There can be cataract can be seen in cases of case conditions like galactosemia, Wilson's disease, and also seen in Lowe syndrome.
Predominantly Lowe syndrome is the predominant condition because Lowe syndrome is a common proximal artery causing refractory rickets. Wilson disease is not very commonly seen, even though mentioned, but it can present, but mainly adults and adolescents and all. Galactosemia, mainly the presentation will be predominantly with systemic manifestations like chronic kidney disease, seizures, etc. So those presenting with rickets associational characteristics mainly it is a Lowy syndrome you can consider. Okay, so apart from the eyes, any other abnormality, Lowy syndrome? You can get another important ocular abnormality of Lowy syndrome with the refractory rickets is you can get glaucoma also. So how will you what is the finding in the eyes if there is having glaucoma?
They can be megalocornea. Can be.
Megalochronia will be the symptom, and even in ophthalmos, microphthalmos also can be occur in the prolonged cases. So megalocornea is characteristic. So you can look for that also. So there is no cataract, there is no megalocornea at least. Okay, so you please describe the main finding you got is evidence of rickets.
Yes, sir.
So please describe. So what is in the chest you got
There is
rachitic rosary. So is it a scorbutic or how will you differentiate? Usually asked question. How will you differentiate a scurvy rosary due to scurvy and rickets? You know, in vitamin D,
usually as
rickets it is rounded and painless.
painless.
So
Usually,
mainly it is due to rounded and painless because due to the widening of the metaphysis of the ribs is the cause. That's why it's a widening of the metaphysis causes widening. It's a painless. Whereas in scurvy, what is the mechanism? It's a
painful.
angulated and tender. So why? Because there is a subluxation of the end of the rib. Mainly, it is a cartilage subluxation. Subluxation of the cartilage causes tending. Very sharp edge of the bone causes angulated tender. Usually asked. Anyway, so there is a having costochondral bleeding is there. That is okay. Then lower limbally, the deformity side is having.
Yes,
Identification of deformity. What is the importance of identification of deformities? Because these are important deformities you have to identify specifically so that you can ask for the ortho surgeon for the correction. Once you treat the underlying cause, once it is healing or healed, you can ask for specific. Sometimes they may need surgical correction and all. So that's why the specific deformity you are supposed to identify. So you have identified coxa vara. Why it is so why do you say it's a coxa vara? So please show the okay coxa vara.
yes.
The femur is
Femur is
deviated
deviated inwards as compared to the hip
inwards
bone, and
compared
there's
to the so it's a
exactly
coxa vara. Okay, so and you told it's a
yes,
genu
genuine
vara
valgum.
valgum deformity. It's both sides.
Yes,
Okay, so these are the two important. So they may need. Is it causing limitation of the patient's
sir, there is
daily
difficulty in walking
activities?
for the child.
Child is not able to walk. He
Yes, sir.
cannot run.
Child cannot run. Child can walk, but with difficulty.
Difficulty. What about climbing? So these points, I think you are supposed to detail in the history
Okay, sir.
because the disability child is having is due to the deformities. That is one point we didn't discuss. So you can discuss more detail. Due to the difficulties, deformity child is not able to climb stairs. How the child is climbing stairs with the help of hands or
Yes, with the help of
hands.
hands.
Okay, so that is one thing you have to need correction and treatment. Then what about is there any frequent falling?
The noise of frequent falls.
You cannot run with the peers.
Yes, sir.
Yeah, he is always going back.
Yes.
Okay, so these points you can highlight so that this need you are supposed to address these points. Okay, so probably these are the deformities causing. So you may seek a surgeon's opinion and all for that. So why do you say it's a valgus deformity of the hip knee joint?
Because there's a tibiofemoral angle can be measured. It is more if it is more than 12 degrees, it is taken as genu valgum, and there is also intermalleolar distance. If it is more than 8 centimeter, it is considered as genu valgum. Here the distance is
Oh,
12 centimeter.
okay, very good. So you, mainly you we will be clinically we look for the intermalleolar distance. Here the distance is what is the intermalleolar distance?
So 12 centimeter.
12 centimeter. So in various clinical methods and textbooks, there are different value for intermalleolar, intercondylar. So distance they have mentioned. So you can refer any of the standards. So 8 centimeter is from which? What's the reference?
So please text of orthopedics.
Orthopedic. Okay, okay. So I think in Nelson they have mentioned 3 centimeter. I think. Did you read? I think it's in Nelson. It's only 3 centimeter. So anyway, the reference. The only thing is you quote the reference. So whether the intermalleolar distance is increased, so there is a genu valgum deformity both more in the left side
Left side as compared to the right.
compared to right. Okay, so did you measure in the lying or sitting position, standing position?
Standing position.
So it should be always measured in the standing position. So you make the chair stand upright and so that the both feet should be approximated as far as possible and see the distance. And what is the cutoff point for genu varum deformity? You measure the intermalleolar distance, isn't it? In intercondylar distance in genu varum. Here, this side is not having genu varum. So, what is the cutoff point for identifying genu varum? Intercondylar, intercondylar. Usually, again, I think it's 3 centimeter in Nelson. Certain clinical methods, it is mentioned as a 5 to 10 centimeter, etc. So there is no uniformity. The only thing you quote the reference. I'm also not able to say which is standard. I think our seniors can clarify that. Okay, sir, Purushottam sir told something. സാർ എന്ത് പറഞ്ഞ ക്ലിയർ ഉണ്ടായിരുന്നില്ല ഏതാ
ഇല്ല ക്ലിയർ അല്ലേ
ഇല്ല 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 സാർ കേട്ടില്ല എനിക്ക് അതിന് എന്താ ഇതുണ്ട് സാറ് വാട്ട് ഈസ് ഞാൻ ഓക്കെ ഓക്കെ സോ ഈ നെൽസൺ 3 centimeter എന്ന് പറയുന്നു okay okay Naveen you can so these are the main findings child is having so we have there is how did you identify the double malleoli? Yes, also. Is it a inspection or palpation, which helped you?
Palpation, basically.
Palpation. Usually, it is you palpate. Always palpate for the double malleoli. Don't examine and just casually say there is no double malleoli. Most of the time, the examiner will be palpating and identifying. You may be easily missed by a student. Okay, you have palpated and identified. So this child is having general examination. You are saying that you didn't get any clue. What about the dentition?
There is no incisors are not formed. Upper incisors are not formed, and there is dental caries are present.
Okay, so that may be you are also history and the finding also correlated with extensive dental caries.
Yes, sir.
Okay. Any procedure for any dental procedure? You can ask for that. Suppose they might be having what is the specific lesion in X-linked rickets, hypophosphatemia rickets? Rather than caries and all, non-specific may not be even they can have
enamel
hypodontia, hypodontia, then cyst, that is epidermal cyst. Presence of epidermal cyst or doing surgery for epidermal cyst in the early childhood is an important clue for a hypophosphatemia rickets. Okay. Anyway, there is a dental caries present in this case. Okay. So you have done general examination. So what is main? Did you get any finding in favor of your diagnosis?
From the examination, there is also more involvement of the lower limb, significant involvement of the lower limb as compared to the upper limb, and also there is dental caries are also noted in the child.
Okay, so you take it in favor of your diagnosis, hypophosphatemia rickets.
Yes, sir.
Yes. Okay. So no, nothing to suggest to renal rickets.
No, sir.
So what are the important points did you look for renal rickets?
Features of any features of cystinosis can be seen like
Okay.
then
You can mention about the hypertension and in chronic kidney disease anemia. The stigmata of CKD you are supposed to mention. That I think you have not highlighted. Pallor, hypertension specifically. Pallor may be common, but hypertension, cystinosis also you can get pallor. So hypertension is very important. Then tibia varum. It is a tibia varum, especially lower third of the tibia and with a deformity, variant deformity is thought to be a specific for renal rickets. And acidotic breathing, you can mention. Dehydration. So these children will be, especially proximal arteries, they'll be having significant dehydration and acidotic breathing, then hypertension. All these suggest renal rickets. Okay. So this child is not having any points in favor of renal rickets.
no, sir.
Okay. So now continue.
To the anthropometry, the weight for age is was 18.4 kg, which is between 3rd to 10th centile at minus 2.33 standard deviation, and height for age is 107 centimeter, which is again less than 3rd centile at minus 4.12 standard deviation, and the BMI
Okay,
is
so you please summarize the anthropometry. I think we have not much time.
okay, sir.
So what is summarize
There is
anthropometry?
height is more affected as compared to the weight in this child, and the BMI appears to be normal with normal head circumference, and the mid-parallel height is also less than 3rd centile, with the mother's height more affected as compared to the father's side, and the upper segment lower segment ratio is normal for the age. So it is a proportional short stature with a family history of short stature also in mother also.
Okay, so how will you discuss this anthropometry in brief? So this child is having a short stature
Yes,
because the height is below 3rd centile. In the which growth chart did you plot?
WHO, IAP group chart.
IAP growth chart because its age is above 5 years. So it's
Yes,
IAP growth chart anyway. Okay, so and the set score also you calculated. Set score is more than -3.
yes, sir.
So according to WHO as well as IAP growth chart, that is having significant stunting, short stature, which is you told that is the main finding, isn't it?
Yes, sir.
There's no wasting,
No wasting.
no wasting. So this type of anthropometry supports.
More
Uh, mm,
hypophosphatemic rickets, because in our proximality there may be more affection of weight also
weight.
might be affected in the RTA renal tubular
Okay.
ascites.
So there is no wasting, and there
And
is no weight for underweight is also not there. Mainly the height is only affected. As a predominant, there is no FTT. As you cannot apply FTT here, still there's no wasting. So there is that is a one point in favor. That is that is a point against, or you may not immediately consider a renal rickets. Even chronic kidney disease also you will get a significant growth retardation. So only the height is affected. That is supporting your hypophosphatemia rickets. That is your argument. Okay. So okay. So any other point you told upper segment,
also
lower segment
mother
ratio
having
normal. Normal. So what is that?
usually the in hypophosphatic rickets the lower limb will be affected, leading to a disproportionate short stature. But here we are having a normal upper segment to lower segment ratio. Uh,
Okay. So yeah. So it's unlikely.
could be a mother's height is also lower side on the lower side. It could be a
Hmm.
part of familial short stature.
Okay. Mother's short stature could be, you can take it in favor of a uh, you're saying
Hypophosphatemic,
familiar short stature.
hypophosphatemic short rickets.
Hypophosphatemia rickets. Okay, that one other side is okay. No, no. I'm asking what about upper segment lower segment ratio? So usually you told previously that the upper segment lower segment ratio there will be a short limb dwarfism will be the
Yes, sir.
in rickets. So here you are not getting.
No.
So how can you explain? Are you going to how you are going to explain that? You measured correctly.
Yes, sir.
Okay, so how will you measure the lower segment?
We take the
In
total
standing
height,
position.
standing position, total height is measured,
Yes.
and then in the sitting position, we measure the upper segment ratio, and we subtract it from the total height.
Okay, that's one method. Any other method?
Can measure also from the pubic symphysis to the in the standing position, we can measure from the pubic symphysis to the ground level, which we can take the as the lower segment ratio, lower segment length, and we can
Okay, I
subtract.
think. Okay, so in this case, which method did you
Actually, both methods were tried, sir. With both
you
yielded
got
the
same?
yes.
Okay, so method you can stand. The child should be in the standing position from the pubic ramus to the ground, especially in the ground at the level of the inner margin of the heel or the feet is the second point in lower segment. Okay, so upper segment lower segment ratio seems normal. So still, do you consider you consider it is a hypophosphatic rickets, isn't it? Okay, so I think you can take it again because physically you demonstrated that the child is having significant deformities of the lower limb, and it is a lower limb deformity causing the short lower segment. So even if measurement is not proving, physically child is having significant handicap
Okay.
due to the lower limb deformity. So that itself suggest that you can take a very strong point in favor of a hypophosphatic rickets, even if you are not getting a lower segment normal or no, even if you are not getting a short limbs.
Okay, sir.
Okay, so the anthropometry also you are supporting mainly it's hypophosphatic. Can it be a vitamin D dependent?
But mother site is also on the lower side, and there is no failure to thrive as per the.
Okay, so there's no failure to that. That's very important. And the history also, no history of hypocalcemia. Without any treatment, the child will not be surviving. Okay, so vitamin D dependent is very unlikely. Okay, so that's about anthropometry. Yeah, then continue. So this is a growth chart. Okay, yes.
Coming to the systemic examination, gastrointestinal system, all dental caries are present. Abdomen is not distended, umbilicus is central. All quadrants are moving equally with respiration. No scars or dilated veins. Hernial orifices are normal. There is no tenderness, soft and palpation. No hepatosplenomegaly. No other palpable mass identified. And coming to the respiratory system, upper airway is normal. There is trachea on the midline. Bilateral chest rise is equal, and bilateral normal vesicular breath sounds heard in all areas. No added sounds are noted. CVS apex is at the left fourth intercostal space at the midclavicular line. First and second heart sound heard with normal intensity, and there is no murmurs. And CNS, the higher mental functions are normal for the age. Cranial nerves are normal, and motor system bulk normal and comparable. Tone is normal in all four limbs, and power is 5/5 in all muscle groups, and reflexes are stable normally. And the sensory system is also normal. In the musculoskeletal system, there is limbing gait with no joint swellings or joint effusions, and no bone tenderness is noted.
Okay, is there any gate you have? Any? Can you demonstrate? Did you have any video and all? Please show
No,
them.
uh,
Not having. Okay. Okay, so system examination. Any finding you got?
no, sir, it was normal actually.
No. So you examined which system? Examined the initially first
Abdomen, GIT was examined
abdomen.
first.
So you examined GAT first. That's right. So you are supposed to look for hepatomegaly. Hepatomegaly is not present.
No, sir.
Usually, if it's a refractory rickets due to a proximal RTA, especially cystinosis, you may get a liver hepatomegaly characteristically. So you will be looking for. Then other rare causes like Wilson disease also, galactosemia also you may get it. Classically, it is cystinosis. You get a hepatomegaly. It is not there. And hypophosphatic rickets and all, you may get. What about the shape of the abdomen? Is there an abdomen distension you will be looking for?
No,
A
sir.
pot belly. due to the lax ligaments, any viscerotosis. Liver is not palpable, spleen not palpable. So
No, sir.
sometimes you will be looking a palpable liver and spleen, but always you have to measure and document that what is the liver span and consistency. And you have to demonstrate that it is only viscerotosis, not hepatomegaly. So these are the points in the history. And in chronic kidney disease, you are supposed to examine for the a palpable bladder, kidneys, also. So especially a chronic kidney disease that is not present here.
No, sir.
Okay, so then you examine the musculoskeletal. So there is no hypotonia. Is there any hypotonia?
No
You'll be
hypotonia.
looking for hypotonia. There's no hypotonia.
No hypotonia, sir.
Hypotonia classically you can get in vitamin D dependent rickets classically, usually, and you can also get in renal tubular acidosis. Also, you can get hypotonia because they may be associated with hypocalcemia, hypokalemia, hypomagnesemia. All are common in children with all these contribute to the hypotonia. So the tone is very important in refractory rickets. So tone you got normal.
Normal.
Okay. Yes. So yes, you can summarize.
Summarizing, it's an 8-year 3-month-old child, developmentally normal, fully immunized, born out of a non-consanguineous marriage, presented with bowing of the legs for the total duration of 7 years. Child had history of multiple fractures associated with minor trauma, and there is history of decreased intake of vitamin D-rich diet, but with no improvement of symptoms on supplementation. Examination showed deformities like wrist widening, rachitic rosary, coxa vara, genu valgum, and double malleoli. So the possibilities consider refractory rickets, mostly hypophosphatemic rickets, renal tubular acidosis, and can also consider vitamin D dependent rickets.
First diagnosis, previous slide. So what is the diagnosis after examination and history and examination? What is the diagnosis? You are mentioning only the difference in this case, but always you try to attempt a diagnosis.
Possibly a hypophosphatemic rickets.
Okay, so you are attempting a hypophosphatemia rickets. Okay, the points in favor, I think you have described many times in the history and findings. Okay, so summarized also. So it's a hypophosphatemia rickets predominantly due to age of onset, predominantly lower limbs, involvement more in the absence with the height affected, short stature. Mother also having short stature, the dental changes, findings on dental changes, and also absence of FTT or wasting, and no specific clue for other DD like hypophosphatemia rickets or renal rickets like CKD or tubular disorders. No clue from the history or findings you got. So that's why you are mentioning. So these points you can highlight that. I think after highlighting this, you can make a first diagnosis as a hypophosphatemia rickets as a diagnosis. But you made a differential diagnosis initially. DED only you can put it. You can take as a refractory rickets as a first. Among refractory rickets, first you are supposed to. In this case, you can straight away no issue for attempting a hypophosphatemia rickets in this case.
Okay, sir.
First diagnosis. Then differential diagnosis, you can say that I would like to rule out other differential diagnosis like, or you will evaluate for these diagnosis.
Okay, sir.
I think any time. What is the time? Mohandas time ഉണ്ടോ നമുക്ക്? Almost 1 hour കഴിഞ്ഞില്ലേ? 1 hour
It's okay. We lost a few minutes of it.
ആണോ? Okay, so investigation ഒന്ന് discuss ചെയ്യാൻ തോന്നുന്നല്ലേ? So how you are going to? So you got a hypophosphatemia rickets first diagram, 2 DDs you told.
Yes.
So are you considering a dysostosis multiplex like dysostosis multiplex like dysplasias or storage? Did you get any clue? No.
No, sir. There was no organomegaly was not noted, and there was no failure.
And higher mental function is normal.
Normal.
no deformities, no organomegaly, no environmental function normal, development also normal.
Normal.
You are not suspecting at all. And you are not getting any deformities of the spines also.
Yeah.
No kyphosis. You'll be looking for kyphosis, scoliosis also. Especially you can get. And osteogenesis imperfecta, are you considering? Few points you can also, for completion, you can also mention about the few clues. Diagnostic clue for osteogenesis imperfecta also, because the severity of the osteogenesis imperfecta manifestations are very varied. It may be mild presentation. So that point we didn't discuss. So like any blue sclera, and you can get short stature also here also. Deformity is possible. And laxity of skin you can look for. Non-healing ulcers you can ask for. Deafness, very common. So deafness also osteogenesis imperfecta. So these are the other points when you present you should be thinking.
Okay, sir.
Few points in the history.
Okay, sir.
Okay. So then you will take what is investigation?
This was the
What is the
initial
first
investigation.
investigation? I think your first investigation is what in a child with the rickets.
We do calcium, phosphorus, and LP is the first line.
Is it a blood investigation? Diagnosis of rickets, clinical diagnosis of rickets is always radiological. You confirm rickets, you are anyway, this is already multiple times. This child, in this case, again, you will be analyzing the X-ray first before you go to the specific investigations. The first diagnosis is X-rays. Okay, so which X-ray will you take for confirmed rickets?
Instead of the wrist can be taken, sir, in AP view.
Which hand? Which hand?
Non-dominant hand, left hand.
Non-dominant hand, left usually. Non-dominant hand. Why do you want to take a rickets wrist?
Because the findings are most commonly seen around the radius and the ulna, and ends of the radius and ulna.
Early, and they will be starting with on supporting on hands, and or earliest finding usually occurs in the wrist joint, and it's a complex joint. Multiple lot of complex movement occurs in this joint, so the stimulation of the bone growth is maximum in this radius and ulna. So that's why you are taking an X-ray of the left hand. Okay, so I think due to lack of time, can you please mention the important findings for rickets? What are the usual findings for rickets
There can be
present
associated
in this case?
fraying, which is irregularity at the end of the bone, or it can be due to cupping due to the concavity of the end of the bone, or
Okay.
there can be widening of the growth plate and the metaphysis can be seen, and there can
Okay.
also be sometimes rarefactions of the generalized rarefactions of the bone can also be seen, or coast.
So these are coarse trabeculation. Okay. So you told fraying, cupping, and widening. Splaying means widening. Widening of the which part will be look for findings?
In the growth plate can be seen, and also the metaphysis. Later on,
Mainly the metaphysis. Metaphysis is the thing. You'll be looking for the metaphysis for these findings. Growth plate. So, what is the earliest X-radiology finding in rickets you may be looking for? Usually asked. It is a widening of the growth plate, widening of the metaphysis. That is a distance from the epiphysis to the diaphysis, where the bone formation occurs. So, epiphysis to diaphysis distance will be increased. That's the earliest sign. So, here can you show widening of the epiphysis? Can you show with the from the end of the epiphysis? Especially you can see in the lower margin, the tip, femur. That is the end of epiphysis, then diaphysis. So this distance will be increased so that there is no newborn formation, the calcification does not occur in this growth plate. So that will be widened. That's the earliest sign. Then there will be cupping, splaying, fraying, rarefaction, osteopenia, very thin cortex, and fractures, pathological fractures also. Okay. So this you can see all the findings are then. So you can get a very thin cortex characteristically. Yes. Now come to so there is a rickets. It is still not healed. It's a recent X-ray, isn't it?
Yes, sir.
Okay, recent X-ray. So for several years, still it is it's not healed. So there is a refractory rickets. Yes.
So next we do the blood
Investigation.
investigation, and we look for mainly calcium, phosphorus, alkaline phosphatase, and PTH, parathyroid hormone levels, and vitamin D3 levels can also be looked. These are the
So these are the investigations. So any other investigation? So you are looking for the calcium and phosphorus. Okay. So you can identify hypophosphatemia rickets and vitamin D dependent rickets, also all type of rickets. Phosphorus is the alkaline phosphatase. What is the comment on alkaline phosphatase in rickets?
usually in all cases of rickets, the alkaline phosphatase will be elevated.
Okay, so it is non-specific.
Not specific.
Whatever the type of etiology, you will get elevated alkaline phosphatase. Okay. What about PTH?
PTH in hypophosphatemic ricket, the PTH level will be normal. If the PTH is normal, it rules out any kind of vitamin D deficiency rickets can be ruled out.
Okay.
If the PTH is normal.
Okay, that is a very important point you have mentioned. So, in a child with rickets, if the PTH comes as normal, you can exclude vitamin D either deficiency or dependent rickets. All types of vitamin D dependent rickets and even nutritional rickets you can exclude. So here also you get a PTH is normal, so you can exclude a vitamin D dependent rickets. Okay. Now, next important investigation we have to discuss is what is another investigation you are suspecting. You are discussing about tubular renal rickets also.
Yes.
So what is important clue in an
ABG.
office practice? Before that,
ABG.
you will be looking always the electrolytes, other electrolytes other than calcium and phosphorus. You'll be seeing the potassium level. So what is the potassium level?
Here it is 5, sir. Usually it is hypokalemia can be seen associated with the renal tubular acidosis.
Okay, so always you will be looking for, is there an hypokalemia? Hypokalemia usually supports your either proximal as well as a distal artery. You may get hypokalemia. So, and hyperkalemia is also likely. So if there's a hyperkalemia.
Can be distal RTA can also present with hyperkalemia also.
What type?
Can be distal RTA or type 4 RTA can present with
Type 4 RTA. So if there's a type 4 RTA, you can get rickets, acidosis, as well as hyperkalemia. So the electrolytes, sodium, potassium is also very important investigation. You will be you will be performing in all cases of rickets. Okay, so here there is no potassium is normal. Yes.
yes.
Now, further.
When we did a urine fractional excretion of
No. So I think you can what is usually initially you do the calcium phosphorus, alkaline phosphate, PTH, and electrolytes, and as a general evaluation, acidosis. ABG is also very important investigation in children with the refractory rickets before going to the specific investigations. So generally screening or as a part of approach to a child with refractory rickets, ABG, electrolytes, apart from the calcium phosphorus, PTH, and alkaline phosphatase, this also we are supposed to do. So in ABG is very, very important. The role of ABG.
So ABG we can identify renal tubular acidosis with the ABG. There will be.
So what type of renal tubular acidosis you get?
Usually it's normal anion gap metabolic acidosis can be seen. In case of
Okay, so you will be looking for a normal anion gap metabolic acidosis. One more specification, one more characteristics of this. What is a chloride? Hyperchloremic normal anion gap metabolic acidosis is, if you are getting, you can very well consider as a renal, especially renal tubular acidosis. Okay. So here ABG you have done. So these are the important, these are the primary evaluations. Okay. Now, with these investigation reports, how will you interpret all these reports? Before coming to the real case, you please show the approach. Then only will be useful. So you can please read that.
In case of refractory rickets, we look at the serum phosphate levels. If the phosphate is already high, we then consider chronic renal failure, CKD as the cause. If it is low or normal, then we look at the pH. If the pH is low, we consider renal tubular acidosis. If the pH is normal, then we look for serum PTH and calcium. If the PTH is high and calcium is low, it is vitamin D dependent rickets. And if the PTH is normal and normal calcium, it is hypophosphatemic rickets.
So this is the approach for a child with the refractory rickets. First of all, you do the phosphorus, and if it is high, it's only one diagnosis. That's a chronic kidney disease. So here you have excluded. Phosphorus is not high, so that's not a chronic kidney disease. Then you do the serum. If it's a normal or low, phosphorus means it can be either refractory rickets due to renal tubular disorders or hypophosphatemia rickets, or even vitamin D. So you do a pH. pH is if it's a low, means it's a renal tubular acidosis. Renal tubular acidosis. If it is normal, it could be either a hypophosphatemia rickets or vitamin D dependent rickets. So this is the clear approach for a child with refractory rickets. So this is a very simple and very clear approach. All of you we can utilize for this case. For this case also you can approach. So you have collected all the investigation for this algorithm. So you have done calcium, phosphorus, pH. You got PTH and all that. So after applying, how will you please apply this?
We have phosphate levels were 2.8 milligram per deciliter, which is low. So then we next look at the blood pH level. pH was actually 7.38, and which can be taken as normal. And then we look at the serum PTH and calcium levels. And here the PTH level was normal, that is 32. It was normal. So it is a possibly hypophosphatemic rickets.
Okay, so the important catch in this case is that you have a low phosphorus. What is a normal phosphorus level, please, in children?
Can be between 3.8 to 6.5 milligram per deciliter.
Okay, so that's generally you can accept that. Generally, it is please refer the values for different ages. So it's not common for children. Depending upon the age, the values are generally the phosphorus level is high in children apart from the adults. Okay, so generally when serum phosphorus level below 3 is generally taken as hypophosphatemia. When only below 3, here it is a 2 point something. And always phosphorus is very important because it's abundantly present in all the food items. So the serum level may be varying from time to time. And it also depends upon the fluid intake, diet you consume, and diurnal variation also. So ideally, it is dependent on the GFR also. So to get an appropriate phosphate level of a child, we are supposed to do 3 days fasting phosphorus. After 10 o'clock, don't take any food. And in the first morning sample, before taking breakfast, they are supposed to estimate the serum phosphorus. You have to take 3 days fasting phosphate level and take the average. So that is the best method for looking for hypophosphatemia. Below 3 is taken as a hypophosphatemia. So here you have a hypophosphatemia, very important investigation. And second crucial point, PTH also. PTH also you got normal.
Yes, sir.
So that's also a very crucial investigation. And ABG, you are not getting acidosis, metabolic acidosis. Okay. So with that, you are coming to the hypophosphatemia rickets. You have excluded In tubular acidosis, you have excluded hypophosphatemia rickets or vitamin D dependent rickets also from the basic investigation you have performed. Okay, now, so you are not going to the renal tubular disorders. Now, anyway, you have to treat, isn't it? So, what is any other investigation you will be planning?
Can
So,
plan.
this is a Nelson. You are showing this different parameters. I think all of us can refer the Nelson. What is the page number, Nelson? You can show the page number because that will be better.
Okay, sir.
Okay. So anyway, or please refer what are the different PTH, alkaline phosphatase, etc. 125 dose vitamin D, 25% level in different types of refractory rickets you can get. Please refer. It's a very important document. This has been present in the all the textbooks on Nelson. They are keeping this table. Very important chart. Please save in your easily accessible software. Maybe you can keep it in your WhatsApp also, this chart. Okay, so I think that we need not discuss due to the time. So now what is next thing?
Treatment can be given.
Before that, so you have a very important crucial investigation. In this case, is hypophosphatemia. So what is the cause of hypophosphatemia in this case?
Cause of hypophosphatemia can be due to multiple conditions like can be due to increased activity of fibroblast growth factor 23, or it can be due to renal phosphaturia alone with normal FGF 23. So FGF activity is increased in conditions like autosomal dominant, autosomal recessive, or X-linked hypophosphatemia rickets.
Okay, I think before that, the mechanism of hypophosphatemia is predominantly it is due to phosphaturia. Predominantly, phosphaturia is the main mechanism we expect. Then it may be also due to very poor diet also. Very poor diet, very prolonged poor diet with calcium and phosphorus, you can get the hypophosphatemia. But it's mainly the renal loss we expect here also. So you got if you are doing appropriately serum phosphorus in 3 days, it's enough. But for the residents and all, there is an exercise to identify the phosphaturia. How will you establish there is phosphaturia in any investigation, specific investigation? Is there any specific investigation you can describe
We can look
so
for
that you
urine.
can demonstrate, you can confirm there is phosphaturia? That is very important for hypophosphatemia rickets. So yes.
Tubular reabsorption of phosphate can be measured using the Bijovet nomogram. We look at the total tubular reabsorption of phosphorus. It is taken as urine phosphate by serum phosphate divided by urine creatinine by serum creatinine. And we get the total tubular reabsorption of phosphorus.
Okay, so you can please refer, all of you can refer this is present in the nephrology textbooks. This is from Arvind Bagga. Arvind Bagga textbook for pediatrics, pediatric nephrology. You can get in the index portion of the textbook. All of you can refer that. So the thing is that you can establish phosphaturia. That is the point, the blood level of serum phosphorus at which level phosphaturia begins. That is what you are supposed to identify. So you can find out what is the blood level of serum phosphorus at which phosphaturia starts. If it is very low level, below 3, you can make a diagnosis of hypophosphatemia rickets. Or not hypophosphatemia rickets, phosphaturia. So this is one nomogram. This is for Bijovet nomogram. Here, for applying this Bijovet nomogram, you have to calculate the fractional excretion of phosphate first initially. For that, you have to do a first morning sample, spot the urine phosphorus, urine phosphate, urine creatinine, serum creatinine, and serum phosphate should be done as a first morning sample, from which value you can calculate fractional excretion of phosphate. 1 minus fractional excretion of phosphate is called tubular reabsorption of phosphate. That means what percentage of the phosphate in the GFR is reabsorbed. That is the meaning of a tubular reabsorption of phosphate. Normally, up to 10 to 15%, up to 85% of the phosphate in the GFR should be reabsorbed. If the tubular reabsorption is less than 85, that is taken as a one point in favor of a phosphaturia. Even still, more specifically establish the point of phosphaturia by applying this Bijovit nomogram, in which you apply serum phosphate level in y-axis, and in the middle diagonal line you apply plot tubular reabsorption of phosphate, and you use a scale. The scale passing through these 2 points will indicate the tubular maximum for phosphate excretion value. That is, tubular maximum for phosphate excretion, TO4 by GFR. That is the point. That point means that the blood level of serum phosphate at which phosphaturia starts. I think it's clear. Maybe confused. Any doubt, you can please ask in this point. I have tried my hard to explain this point. Okay. So this is you can find out the phosphaturia. So in this case, what is the tubular maximum for phosphate excretion?
It is coming around 2.5, sir.
2.5 node. So that means in this case, when the serum phosphate level reaches 2.5, phosphaturia starts. That is the reason for hypophosphatemia rickets in this case. Okay, so you have established hypophosphaturia. So what are the causes of phosphaturia apart from the hypophosphatemia rickets? You can get in nutritional rickets. You can also get in
renal tubular acidosis.
Lumen tubular. Which type?
Proximal renal tubular acidosis.
Proximal. So this phosphaturia could be either due to hypophosphatemia rickets or due to proximal renal tubular acidosis. Isn't it?
Yes, sir.
Okay. Both is possible. But with other evidence, other history and other investigations, proximal RTI is less likely. Now,
Yes.
how will you further? What are the next? So you have almost got a clue, almost reached that at the point of hypophosphatemia rickets. Now, how will you further proceed?
Now we look at the FGF activity and urine calcium are the next steps we can do. Then if the FGF activity is increased, we can consider conditions like autosomal dominant, autosomal recessive, X-linked hypophosphatemic rickets, and others like fibrous dysplasia, McCune-Albright syndrome, epidermal nervous syndrome, tumor-induced osteomalacia, etc. And if there is FGF activity is normal, then we can consider hypophosphatemic rickets with hypercalciuria or Den disease, Lowe syndrome, etc., which can be considered as information.
Okay, so very good. So you have a hypophosphatemia ricket. Now it can be due to either there are many conditions, list of conditions causing phosphaturia and hypophosphatemic rickets with elevated FGF23 level. And there are also list of conditions which can cause phosphaturia and the rickets with a normal or reduced FGF23. So FGF23 may be an important investigation to further find out the cause for hypophosphatemia rickets in this case. Or another important method is you can even straight away go to the genetic study, because all these conditions described in this condition is genetically determined. So you can, even without estimating FGF23, you can do a genetic study and you can get a diagnosis. But sometimes a genetic study may not be always helpful if you are not choosing the optimum ideal study. So FGF23 may be helpful. So the list of condition also, you can please read the list of condition once again. One is autosomal dominant.
Autosomal dominant hypophosphatemic rickets.
These rickets usually, okay, please. So autosomal dominant hypophosphatemic rickets usually occurs in older children. It's not a disease of a very small child. So in this case, it could be But the mother is having short stature and all, and dental changes are mainly suggesting a X-linked here in this case. So autosomal dominant is still possible because a lesser severity. Then
Then can be
autosomal.
recessive
Next
type.
one is
Autosomal recessive type. Then
it's
can
a
be
very rare. This is a very extremely rare case. Extremely rare case. It may be associated with one important clue for it. It may be associated with deafness. There is no deafness in this case clinically, so, isn't it?
yes, no
Okay.
definitely.
Then autosomal dominant type 2 is associated with a specific abnormality. They will be having some arterial calcification and all. So these are very rare conditions. That's also very unlikely. Then,
X-linked hypophosphatemic rickets, most common type.
so this could be X-linked hypophosphatemic rickets. Then,
And can be
mainly
fibrous
characterized by the inheritance. It's the commonest one. Then,
and fibrous dysplasia as in McCune-Albright syndrome,
yes. Then,
epidermal nervous syndrome, then tumor-induced osteomalacia and rickets.
okay. So these are the three important conditions all of us should be aware of. It's a rare condition, but still specific disease. So McCune-Albright and the tumors, especially mesodermal tumors, and epidermal uh, lesions. All these can cause these lesions. This tissue will be releasing FGF23, causing phosphaturia and rickets. So the thing is that the tumor-induced very difficult to identify. The tumor may be very small, very difficult to find out the primary focus. And the McCune-Albright syndrome, usually you can find it out. And the epidermal tumor also, nevus epidermal lesion also, very difficult to identify the primary focus. So these are specific, and when you are not getting any clue with hypophosphatemic rickets and FGF23 elevated, you may have to go for specific investigations like imaging and or lot of specialized investigation may be needed, and the genetic study may be helpful. Then coming to the FGF23 low or normal type of hypophosphatemia rickets, important conditions are
Hypophosphatemic rickets with hypercalciuria, Den disease,
okay.
and Lewis syndrome.
So this is another important. Hypophosphatemia rickets with hypercalciuria is very important. One rare condition. Here the main thing is they will be having rickets, but there won't be any vitamin D. Vitamin D will be normal in this case. Active vitamin D, the 125 atoms of vitamin D will be normal in this case. Whereas in X-linked rickets, you may get the increased activity of the vitamin D. 125 vitamin D level will be inappropriately low compared to the hypophosphatemia. Okay, so these are the more specific points. If anybody want, you can discuss more. Then there are other specific diseases like dental disease, Lowy syndrome, and Fanconi-Bickel syndrome. So these are there won't be much difficulty in diagnosing these because dental disease has got associated features. There will be hypercalciuria and nephrocalcinosis will be associated, and there will be low molecular weight microalbuminuria, proteinuria will be there. You can easily diagnose. And Lowy syndrome usually clinically will be associated with proximal RTA with the neurologically abnormal child, like intellectual disability, development delay, hypotonia, all these features will be there. Now, there won't be much difficulty. And the Fanconi-Bickel syndrome is also, it's a type of glycogen storage disease characterized by the hepatomegaly failure to thrive and the proximal RTA with the Fanconi syndrome. Okay. So in this case, what is further investigation after hypophosphatemia?
Here the FGF activity was low, 11.39, and urine
Low.
calcium. Urine calcium excretion was found to be around 128 mg, which is corresponding to around 6 mg per kg per day, which is a suggestive hypercalciuria. So it could be hypophosphatemic rickets with hypercalciuria.
Okay, so FGF23 was very crucial. So you can exclude a lot of conditions you have excluded by doing a FGF23. You got a normal. So you have limited. You have narrowed the diagnosis to very few.
సార్ మీ గురించి బ్రేక్ ఇంట్రెస్టింగ్ సార్ చెప్పాను మీ గురించి చాలా మంది డిస్కస్ చేస్తున్నారు మీ గురించి చెప్పండి సార్ మీ గురించి
Okay. So there is a hyperphosphatemia rickets with FGF23 low means it could be limited. It is very unlikely to be a tender disease, very unlikely to be Fanconi-Bickel syndrome. Lowy syndrome, no proofs from the history or findings. So the left condition is a hypophosphatemia rickets with hypercalciuria. So the very important investigation you have performed is urine for hypercalciuria. So അതൊന്നും മ്യൂട്ട് ചെയ്യാം. Okay, so at this level, this hyper.
మళ్ళీ సార్ అంటే మీ గురించి సురేష్ సార్ చాలా రోజులు చెప్తున్నారు అనమాట 11% కాకుండా 10% ఒక ఆపర్చునిటీ కానీ సార్ చెప్పారు సురేష్ సార్ సార్ పడే మీ స్టీల్ పంపించిన తర్వాత
Aslam, നമുക്ക് വൈൻഡപ്പ് ചെയ്യാനായി.
Yeah, we have election meeting also.
Hello. Krishnan, you can unmute.
Okay. ശരി. ഞാനത് കേട്ടില്ലേ അത്?
I think.
എവിടെയാ അത് മുറിഞ്ഞു പോയെ?
Is it finished?
Just one or two points. എവിടെയാ അത് നിന്ന് പോയത് അറിയാം?
നമ്മുടെ ഇലക്ഷൻ മീറ്റിംഗ് ഉണ്ട് കേട്ടോ. വെയിറ്റ് ചെയ്യാം.
Okay. ഞാൻ just I think we can wind up അല്ലേ മോഹൻദാസ്? Time exceeded.
I think there is another meeting in the same plan.
Okay. So you have done urine for hypercalciuria. You have estimated which came out to be hypercalciuria because 25 urine calcium was found to be more than 4 milligram per deciliter, 4 milligram per kilogram body weight. So there is hypercalciuria. So finally, the diagnosis come out to be, you are saying that it is a familial hypophosphatemia rickets with hypercalciuria. Okay, I think with that we can wind up. The other treatment or you can please refer.
Thank you, Dr. Krishnan, for this detailed discussion on rickets. And Naveen has presented well. And I'm really sorry for the technical glitches which we had in between. And also, I would like to thank all who have worked behind this for making this program a success. Thank you all.
Okay, Naveen presented very well. You have discussed also all the points you have discussed very well. Congratulations.
Okay, thank you. Good night.
Thank you. Thank you.
Can I end the meeting? Or
in between
should I close the meeting?